And the host for
Yes,
the
hi,
session.
I'm here. Yeah. So,
Okay, so
thank
I'm
you for.
handing over the charge to Dr. Samar. Uh, Dr. Samar, over to you.
Yeah. Uh, Good morning, good afternoon, everybody. Once again, I would like to thank Dr. Nathan and the organizing committee for inviting me for this such a fruitful workshop on ketogenic diet. And without further delay, let me introduce our first speaker, uh, uh, Dr. Shahnaz, and her dietitian Hira Farouk will be talking about tube feeding, blenderized diet, and parenteral diet. So, dietitian Hira works as a clinical dietitian at the Aga Khan University Hospital since November 2016, and she is a registered nurse with the Pakistan Nutrition and Dietitian Society. She is involved with different research projects as well as working with different philanthropic organizations for nutritional improvement. She also mainly work in the field of pediatric nutrition care and ketogenic diet, along with other specialties, surgery, medical medicine, oncology, and ortho. Hira, the mic is yours. You can kick off now.
Good morning, good evening, good afternoon. As per your time zone, my topic is tube feeding and blenderized diet. So we will discuss, as you are seeing in Rokshanaz Brahim's session, related to total parenteral nutrition in a critical setting for a patient suffering from SRSE. This is about intravenous KD, and this refers to the previous presentation. So on day 5th, when the child was achieved with 70% dietary energy needs on TPN, and at this day, this time frame, he was decided to switch to enteral nutrition and continue with the ketogenic dietary therapy. So from here, my presentation will cover on how to switch to the total enteral nutrition from parenteral nutrition slowly and gradually, and how to calculate it to avoid any inconvenience, any gut disturbance, or any issues of aspiration and other issues. So this is the summary table on which we have switched the child to enteral nutrition. Till day 5th, the child was on total parenteral nutrition. On day 6th, he was planned to start with EN. So this is the total prescription on how to progress with EN. On day 6 to 7, there are certain papers who refer on how to progress to from PN to EN, who supported that 1/10 to 1/5 of the caloric requirement, or the total requirement, should be initiated on day 6 to 7 over a period of 48 hours should be given. So on day 6 to 7, 1/3 of the total 70% of the required calories was provided with EN, and rest of the 2/3 will continue from parenteral nutrition. So this just reversed as we have progressed in parenteral nutrition. So this is just a reversal of it, and we just gradually taper down parenteral nutrition and gradually increase the enteral nutrition to avoid any overloading or any overloading of volume or calories from enteral nutrition. So this was the total volume of 600 ml, which was administered initially over a period of 4 hours, 100 ml Q4 hourly, and the rest, 2/3 of the PPN, was continued with the same. So this is the EN prescription of this 1/3 of 70% required calories. It comprised of 44 grams of fat and 5.5 grams of amino acids, and similarly carbohydrate. After day 7th, enteral nutrition was progressed to 2/3 of the 70% calories, and the remaining 1/3 was administered through parenteral nutrition. And this was the total volume, which comprises of 880 calories total from enteral nutrition, of total 900 ml, and rest 440 calories was administered through parenteral nutrition. And this time, a little volume was increased, 50 ml, 150 ml Q4 hourly, and the rest TPN was running with 31 ml per hour. So this is the enteral nutrition support from 2/3 enteral nutrition support from ketogenic diet therapy, and it comprises of 88 gram fat and 11 gram amino acids, and similarly carbohydrate, and the rest is parenteral nutrition. On day 9th and 10th, as we reached to the 70% of the total required calories, the TPN stopped on day 10th, and the child was shifted to total enteral nutrition, complete enteral nutrition, and TPN stopped over here, and we have reached to the rate of 200 ml Q4 hourly, and providing total 70% required calories from EN. This was the prescription of nutrients, which comprise of 132 gram fat, 16.5 gram amino acid, and similarly carbohydrate. So just keep the child for 1 or 2 days with 70% of total required calories, and then gradually we progressed after day 10th to 100% of the caloric requirement, which was 1900 calories, and the target rate of feed was 300 ml every 4 hourly. And this was the total nutrient prescription per day, which included 188 grams of fat, 23.5 grams of amino acids, and carbohydrate. So this is just a summary table of nutrient prescription, which I have done as 1/3 for per day per meal, 2/3, and then 70%, and then 100%. So this was the 1/3 caloric requirement initially for day 6 and 7 that we are providing with enteral nutrition. This is the 2/3 requirement, and this is the 70% requirement, and this is the 100% requirement. The total number of meals planned was 6, and this breakdown is according to these 6 meals per day. Initially, to avoid any aspiration, any gut disturbance, or any intolerance, we just planned to keep the patient on formula feed for day 6 and day 7. And then after day 7, we gradually, as we progress to 2/3 of the EN and then 70%, we just planned to add 1 or 2 or 3 kitchen-based feed, one by one, and gradually 1 feed, and then 2nd feed, and then 3rd feed over the period of time. But initially for 2 days, we just keep the patient on formula feed. This was the 1/3 of the 70%. I am just going to show the 1/3 calculation of the 70%, and then which was the formula feed. One thing I would like to mention over here, as the KetoCal, which is a pure ketogenic formula, is quite expensive in our setting, and most of the families are not very much affording. So we have to use protein and calories and carbohydrate modulators along with this. So we just use proteins and phantomals and olive oil along with the KetoCal to keep this grammage minimal, to burdenize minimally over the parents. And this was the caloric protein fat breakdown for the feeding calculation. These were the goals, total goals, and this was the caloric requirement per meal, which is 73.3 calories per meal, and 7.3 gram fat per meal, 0.91 gram protein, and 0.91 grams of carbohydrate. These are all calculated in grams. Here I would like to mention one thing. Because of the minimal decimal calculations of grams and milligrams, there may be a plus minus of 5-6 calories. So this is negligible and this is acceptable. Here I would like to emphasize again on the distribution of 1/3, 2/3, and then progression to 70%, and then 100% caloric requirement. So this is to reinforce and to remember that the previous slide was related to 1/3, and similarly we will progress after 7 days to 2/3, and then after again 48 hours to 70%, and then after day 10th this was progressed to 100%. So I am just skipping 2/3 and 70% of the calculation and just showing you the 100% of the calculation of blend-raised feed, kitchen blend-raised feed. So this was the first option, and then gradually, as I have mentioned about the second option and the third option, as per the calculation and tolerance of patient, we just included them also. This was the first option, which comprises of boiled egg as a source of protein, apple without skin as a source of carbohydrate, then cream and olive oil. This was the breakdown. This was the total breakdown of fat, protein, and carbohydrate, and total calories per meal. So total calories per meal was 316, and the total fat required was 31.4, 3.91, and protein and 3.91 of carbohydrate. As the child was on enteral nutrition through NG feeding, so we advised parents to blenderize all the food items as per the given grammage in a lukewarm water, as this is more easy to feed the patient and avoid any kind of intolerance or blockage or other issues. And then we advise them to make it to the desired consistency or make the volume up to 300 ml, and then strain it also to avoid any kind of blockage with all the feeding guidelines. So thank you. This was the total progression we have done for this patient, and thank you. This is it from my side.
Thank you for the wonderful talk. Our second speaker is Dietitian Sonal. She's a chief clinical dietitian working with Dr. Nathan Clinic. She has a ketogenic therapy experience since the last 10 years. She holds MCS clinical nutrition and dietetics, PGC certificate diabetic education as well. She will be talking about fine-tuning, switching, and weaning diet.
Hello once again. I'll be now speaking about follow-up, fine-tuning, and weaning of ketogenic diet therapies. Let's begin with follow-up first. It is essential that patient follow-up should be done by the KD team of doctor and dietitian every month for better KD efficacy and patient compliance. What to look for in every patient follow-up? We check the patient's anthropometric measurements like their height, weight. This is to calculate the ideal body weight and also to check for the BMI growth trends. The ideal body weight is calculated as per the regional norms. At our center, we calculate it using the IAP or the ICMR growth charts. This in turn helps to decide the ketogenic calories. The urine ketones are checked in the clinic during each follow-up. This is to cross-check the patient's keto diastics. The blood ketone check is sometimes done at our center. Blood ketones is useful if the patient's urine ketones are optimal, but the seizure control is not good. We also ask the caregivers to maintain the patient's urine ketone chart, where they note down the urine ketones every day, and they bring this chart to the clinic at every follow-up. Similarly, we also ask the caregivers to maintain the patient's seizure chart, where they note down the seizure frequency, and this helps to assess the seizure frequency as compared to previous month. The video EEG is done at baseline and then repeated every 3 months in the first year and then every 6 months. This helps to check the epileptic activity in the EEG, which can often be silent or at a time associated with clinical seizures, which in turn may be obvious or subtle. The urine routine test is also done every month to check for crystals, RBCs, urine calcium to creatinine ratio. The blood test is also done at baseline and then repeated every 3 months in the first year and then every 6 months. This is to check for any deficiencies or abnormalities in the blood parameters. We also check for some side effects and symptoms like drowsiness, nausea and vomiting, constipation, or dehydration. And if we notice any of this, we do correct it with appropriate supplementation and medication. There are certain less common side effects and symptoms which we have seen in our clinic, like changes in sleep and behavior patterns, temporary memory loss in some kids with increased seizure frequency. So we have to treat it appropriately. We also check for SP's feedback from the caregivers and the patients. This helps to maintain the patient compliance to the ketogenic diet. So what are the problems during ketogenic diet and how do we tackle them? So there have been problems with the weighing scale, where the caregivers unknowingly change the settings of the weighing scale, like example, changing the units from grams to ounces. This leads to alterations in the amount of food required. They don't keep a spare weighing scale in emergency, where the caregivers use approximate measurements on their own, which can lead to a fall in ketones. They also fail to get the weighing scale for calibration during the follow-up. So we always have to counsel them and recommend that they should be getting it at each follow-up. There have been problems with weighing food items. So many caregivers are not aware of how to cook the keto meals and how to weigh the food items. So they may do it inaccurately. For example, weighing cooked vegetables and meat instead of weighing it raw. So we have to explain them at each follow-up. We have to ask them questions and gain information as to how they're preparing the meals, and then we have to correct them. Problems with changing brand. So there, for many caregivers, what they do is they don't know that certain products may contain sugar. So we always, teach them that they have to read the labels. Now, here the example is use of Sofit flavored soya milk. Now, Sofit is a common soya milk brand available in India, and we recommend that to our patients. And we always recommend the unsweetened version. But many parents don't realize that, and they end up buying the flavored version, which contains the sugar. So we have to always counsel them to read the labels, and if they are unable to do so, or if they have any problem, we ask them to take a photo of the product and WhatsApp it to us or email it to us before buying it. So once we check and approve it, then they can go ahead and buy it. Problems with substitution of ingredients in recipes. Some caregivers may substitute certain ingredients from the recipes without our knowledge, and this leads to imbalance in calculations and a drop in ketones. For example, substituting almonds for cashew nuts, which we know have different nutritive values. Problems with list of vegetables and fruit. So to all our caregivers, we give an exchange list of fruit and vegetables in the fruit A and fruit B list. And sometimes you don't read it properly, and this leads to the choice of wrong ingredients. Problems with food taste. So some caregivers don't, add appropriate spices or herbs to the keto meals, and some of the children don't like the taste of it. So during each follow-up, we always question the mothers as to how they prepare the meals, whether they add any spices or herbs, and then we teach them how to go about it. And we know that many spices also have anti-seizure benefits, so we teach them about this. And once they do that, then the patient starts liking the keto meals, and they complete it with relish. Problems with water intake. So some of the caregivers don't boil the water for 20 minutes. In our country, we recommend everyone to boil the water for 20 minutes to minimize the chances of infections. Also, many patients don't drink adequate amount of water. So this can lead to dehydration and can also lead to wrong urine ketone readings. Similarly, they may end up drinking too much of water, which leads to diluted urine, and can again in turn lead to wrong urine ketone readings. So the indicator that we teach them here is that the urine color should be pale or light yellow in color. That means they are drinking adequate amount of water. Okay, and to adjust the water intake accordingly. Problems with keto diastics. So some of them may be confused with with the color, and this leads to wrong readings. Many a times they leave the ketodiastic strips out in the open, and that leads to oxidation and then leads to wrong reading. So we always ask them to get the bottle of ketodiastics to the clinic at each follow-up, and we cross-check it with our own ketodiastics to make sure that the colors match. Next, we proceed with the fine-tuning of the ketogenic diet. The aim of the fine-tuning of the ketogenic diet involves first to achieve 4+ to 4++ urine ketones and to maintain the weight of the patient at the ideal body weight. This helps to reduce the seizures or bring about complete seizure freedom, or even freedom and reduction in the anti-seizure medications. So what is a rule in fine-tuning? It is to make one change at a time, either calories or ratio, and also to wait for 15 to 30 days for stabilization of the urine ketone levels. So what is the importance of 4+ urine ketone levels? Many a times we are asked whether urine ketone should be checked on a daily basis, and if so, whether it should be checked 4 times in a day. So this is a case where if urine ketones are checked only 1 time in a day, so here it's been checked in the morning time, and as you can see in the chart, throughout the day in the morning time, it was 4+. In spite of that, the patient's fits were around 5 to 10 per day. So one would conclude that ketogenic diet is not working for this patient. But the actual ketone chart, as you can see, is that the rest of the day, that is afternoon, evening, and night time, the ketones were dropping to 3+, 2+, or even sometimes 1+, right? And that's why the fits were still present. So in this case, we have to fine-tune the diet to achieve stable 4+ urine ketones. After fine-tuning the diet, the patient reached 4+ to 4++ throughout the day, and the fits reduced to 1 to 2 per day, and ultimately the patient was seizure-free. This is another case where if urine ketones are checked only randomly, that is on alternate days. So this showed 4+. Whenever they checked the urine ketones randomly, it showed 4+ throughout the day. In spite of that, the fits again were 8 per month, and one would conclude that KD is not working for this patient. Now, if you see here, the days they were not checking, the urine ketones were actually dropping. So if they were actually diligently checking it 4 times throughout the day, each and every day, they would see that the urine ketones are dropping sometimes, right? And that's the reason why the fits are still there. So once you fine tune the diet in either calories or ratio, the patient reached 4+ to 4++ ketones. The seizures reduced by 70%, and ultimately the patient was completely seizure-free. Now, strict daily monitoring of urine ketones is very important. So we recommend caregivers to check the urine ketones 3 to 4 times daily. The advantages is that it is useful in fine-tuning of ketogenic diet, identifies cheating if they eat extra food or if they eat any carb-rich foods, we get to know that. Consistent urine ketones of 4+ gives better results compared to those who maintain lower urine ketones. Now, this is an example of a patient with high ketones, which led to good seizure control. And when the patient cheated, this led to lower urine ketones and the seizures increased. So this patient had myoclonic seizures, and baseline seizures were 210 per month. The reason for recurrence of fits was because the mother was giving extra food to the child. If you can see the table, till 4 years, on ketogenic diet, the caregiver and the patient were maintaining appropriate optimal 4+ urine ketone throughout the day, and the ratio then was 2:1, and the patient's seizures were completely nil, and he had 100% seizure control. After 6 months, what happened was the mother started giving extra food to the child, and as you can see here, the ketone started dropping, especially in the morning and the afternoon. And the keto ratio, you can observe, was less than 2:1, because we were trying to taper the patient's diet since he was doing so well, and we were not aware that the mother was giving the extra food to the child. The seizures then increased to 4 per month, and the seizure control was 96.2%. At 6 years on ketogenic diet, the urine ketones started dropping all the time to 3+ and 2+. And if you notice that the mother was not even checking it all the time, she was not checking it in the night time. And this was when we had actually increased the keto ratio to 3:1. And the seizures then had increased to 90 per month, and the seizure control was only 62.5%. So this shows that poor follow-up, poor compliance, and not checking ketones 4 times a day led to this situation. This is another case where poor maintenance of ketones led to no seizure control, but when the patient reached 4+ ketones throughout the day, there was 100% seizure control. So this male patient also had myoclonic seizures and had 900 seizures per month baseline. Till 4 months of on ketogenic diet, the urine ketones were mostly in 3+ range, as you can see, and the patient was on 2 to 2.2:1 keto ratio. Even with this, there was 50% seizure control. From 900, the patient seizures went down to 450 per month. At 1 year on ketogenic diet, you can see that the urine ketones were much better. It was mostly 4+ throughout the day. Only very rarely you can see that the ketones were dropping to 3+, mostly in the afternoon, evening, and night. The ratio we had increased to 2.5:1, and the seizure control was 83.3%. So the seizures had further reduced to 150 per month. And at 1.5 years on ketogenic diet, the patient had optimal 4+ to 4++ urine ketones throughout the day on 2.7:1 keto ratio, and the patient had reached 100% seizure control. So there were no seizures. So this is the urine ketone chart of the same patient, the second case that I showed you. So till 4 months, you can see there was 50% seizure control. So here, mostly you can see 3+ and 2+, that is marked in red throughout the day, and very rare of 4+. In the second chart, where the patient had 83% seizure control, you can see more of 4+ to 4++ marked with a blue pen, and very rare, drop in urine ketones to 3+. And at 1.5 years, when there was 100% seizure control, you don't notice any red here. That means there were no lower ketones. Mostly it was optimal at all times. So what limits ketones? Inadequate or excessive calories, meals that have been spaced too far apart, not consuming all of the meals, vomiting or diarrheal episodes, inadvertently eating foods having hidden carbohydrates, parents or patients cheating, like that is eating extra food, and even carb-rich foods. So what are these hidden carbohydrates? What we need to consider is that toothpaste also contains sugar. So at our center, we recommend sugar-free toothpaste. Also, mouthwash contains sugar, carbohydrates, so that can lower the ketones. Sauces and salad dressings also contain sugar sometimes, or other ingredients which can lower the ketones. Chewing gum, use of thickening agent in products like maltodextrin. Sweeteners like some sugar alcohols. Now at our center, we recommend erythritol, which is also a sugar alcohol, but that doesn't spike the glucose in any way, and it is keto friendly. Whereas sugar alcohol like maltitol has a higher glycemic index and does spike the blood glucose and lower the ketones. Medications, so cough syrups, dispersible tablets, sugar-coated tablets contain sugar and can again lead to a drop in ketones. Low carb or no sugar added products. Now, although they may not typically contain sugar, but they may contain some high carb food which can lower the ketones, right? So it is very important to read the labels. And changes in product formulation. So if a formulation of a product was initially sugar-free, it can so happen that they change the formulation later and can contain certain ingredients like maltodextrin, which is a thickening agent, and we know that that lowers the ketones. So we always counsel the patients that they should read the labels at all times, and if they don't understand anything from the label, they should always contact us for that. How to improve ketones? So some patients benefit from higher level of ketones or increased blood ketone levels, while others at milder or lower levels. Rarely, some may have an increase in seizure frequency with higher ketone levels and a better control of seizures with reducing the ketones. Therefore, ratios have to be adjusted to optimize the ketone levels and potentially diet efficacy if necessary. MCT oil is also gradually incorporated and titrated to enhance the ketones. Monitoring of free carnitine levels and initiating supplementation may increase KD efficacy. And short periods of fasting may enhance ketones and potentially increase the efficacy. Urine ketones is affected by various modalities. So difficulty in collecting urine from diapers, soiling of urine with stool. So in such situations, one cannot really check for the urine ketones. Problems with menstruation. So during menstruation, many female patients may not find it comfortable to check for the urine ketones. Water binging, cheating, illness or fever. So in the urine ketones, we cannot detect how high it is. So the highest we can measure is as per the 4++ method. So blood ketones gives us a better level there. So we get to know what is the actual level. The same cannot be said for the urine ketones. Some children pass urine infrequently, so we cannot sometimes check it 4 times in a day. So if the patient has constant 4+ urine ketones and seizures still not halted, and if the blood ketones is low at this stage, so we have to increase the keto ratio, and then the seizure halts and it's in control. So there's no direct correlation between the urine ketones and the blood ketones. So the blood ketone check is needed for more than average patients. In rare situations, if the blood ketone is very high, that is 5 to 6 millimole per liter, and the seizures have increased. So in such cases, we reduce the keto ratio and the seizures reduce accordingly. So the blood ketone is an accurate measure of ketones, but it has its own set of disadvantages because it's a invasive method. It can be painful. The test strips and the monitor is pretty expensive. Wrong results if the machine is defective and the patient doesn't realize that. Useful when urine ketones is 4+, but the seizures are not controlled. So this is one advantage of using the blood ketones, that when the urine ketones is 4+, the seizures are not controlled, we can go for the blood ketone check. Now, this is an article by Donald et al., where he checked the seizure control, which correlates better with the blood ketones rather than with the urine ketones. Now, in this table, you can see that the urine ketones of the patient and the blood ketones were checked simultaneously. So when the patient's urine ketones were 4+, some of the patients still had lower blood ketones. So the minimum was 1.4, right? So on changing the ratio and or calories to increase blood ketones, the seizure control improved in 5 out of 11 patients. So we know that there's a wide variation. In spite of the urine ketones being 4+, some of them had a lower blood ketone levels and the seizure control wasn't seen in them. So this is blood ketone check is very beneficial for those who have lower seizure control and optimal urine ketones. Now, this is a case study which was done at our center. So this patient, as you can see, was on the diet, and the seizure frequency at the beginning was 34 per day. Throughout the entire time, you can see that the urine ketones were 4+, but the blood ketone was low when the diet was started. It was just 1.3. But when when we increase the keto ratio, that is from 1.3, we increase it to 1.5:1. After 1 month on KD, the blood ketone levels increased to 3.4, and the seizure frequency went down to 26 per day. Post 2 months, we further increased the keto ratio to 1.8:1, and the blood ketones also increased to 4.8 millimole per liter, and the seizure frequency further reduced to 12 per day. And post 3 months, the blood ketones on the same ratio increased more to 4.5, and the seizure frequency reduced much further to 8 per day, and now the patient is completely seizure free. The next aspect that we checked for in fine tuning is the meal timing. So we always evaluate the timing of the patient's meals. We aim for not more than 3 hours gap between the meals. If there's a longer gap, that can lead to a drop in ketones. We also aim for no more than 12 hours gap between the last and the first meal. If the ketones are low in the mornings, we always consider a late night meal for the patient. And we always recommend that calories should be equally spread throughout the day. How do we initiate a diet for an overweight patient? So we have to reduce 100 kilocalories from the 75% of the recommended dietary allowance, and this helps to achieve the desirable body weight. It is essential to burn the excess body fat, and we also consider the activity level of the child. In these patients, because they are used to having a larger portion size, so we try to give a more bulky food, bulky meal for them, so less concentrated recipes. And we also ask the caregivers to use from the group A of vegetables and fruits. Initiating diet for underweight patients, so we have to increase 100 kilocalories from 75% of the RDA to achieve desirable body weight. If less calories are given, the patients will burn the body protein, that is muscle, which we do not want. We also consider the activity level of the child and then prescribe the calories accordingly. In this case, the patients may not complete their meals, so we try to give a more concentrated recipes and also ask the caregivers to use the group B vegetables and fruits. Now, how do we choose between keto and modified Atkins for the patients? So our first choice is always ketogenic diet, but in certain situations, we may prefer to go for modified Atkins. So if a patient is on ketogenic diet, if they find it too restrictive, or if they are feeling hungry, and because we know that KD is a bit more rigid compared to the modified Atkins, if the patient is going to school or college, or if the mother has more than one kid, then we may think of switching the patient to modified Atkins if the seizure frequency is comparatively low, right? In a similar way, if the patient is on modified Atkins, and if we see that there is insufficient Atkins response, if there's lower ketones, the seizure frequency is increasing or has plateaued, or if the patient has not If the parent has not understood the concept of modified Atkins and is making errors, so then we may shift them to the ketogenic diet. So this is an article by Eric Kosoff. So his article was, will seizure control improve by switching from the modified Atkins diet to the traditional ketogenic diet? So retrospective information was taken from 27 patients who made the dietary change from modified Atkins to ketogenic diet from 4 different institutions. They saw that 10 patients had more than 10% additional seizure reduction with the change from the change to KD from modified Atkins. And there was higher incidence of improvement with the ketogenic diet for those who had myoclonic astatic epilepsy. So the results suggested that the KD represented a higher dose of dietary therapy than the modified Atkins, and it was beneficial for those with myoclonic astatic epilepsy. What are the common dietitian mistakes during fine-tuning? Dietitian fixing ratios and calories without discussing with the neurologist. We now know that a KD team of both the doctor and the dietitian is essential when we prescribe ketogenic diet to the patients. Do not take into consideration the ideal body weight of the child. They do not realize that an overweight child needs less calories or an underweight child needs more calories. The dietitian may not adjust protein according to height progression. Sometimes they do not even check the the serum total protein, albumin, globulin levels, and don't adjust the protein as per that as well. Dietitians do not give adequate supplements. Oftentimes they don't realize that a change of brand like milk or cheese can result in disaster due to different nutritional values. So we always inform the dietitians that you should check the branded food item nutritive values, which is given on the back of the pack. Parents are also known to switch the brands without informing the dietitians. So it's the job of dietitian to always counsel at each and every follow-up that the parents or caregivers cannot make a change without the doctor or the dietitian's permissions. So they always have to ask them. Okay. Parents cheat on behalf of the child, especially when child is well controlled for several months. So the parents get complacent and very happy that the child is doing so well, so they can make certain adjustments without taking the approval of the dietitian. So in such situations, the dietitian has to be firm and needs to question the caregivers and then correct their mistakes. What are the common doctor mistakes during fine-tuning? Many doctors do not check the medications for sugar. So several sugar-containing medicines are still continued. Medicines for current infections and illnesses are not checked. Some pediatricians, even after being told not to give syrups containing sugar or any dispersible or mouth-dissolving tablets, they still prescribe them to the patients and tell the parents that the amount of sugar is very minute and will not result in the urine ketone drop. But we see the disastrous results. We have seen that at our center, and we have to. So what we do is we have made a note to the doctor. It's a letter which we hand it over to the caregivers when they begin the ketogenic diet. And we tell them that if they have to see any other doctor or the family doctor, they should hand over this note, which specifically states that any medicines that have been that have to be prescribed to the patient, it has to be completely sugar-free, right? Next, we go on to weaning and tapering of ketogenic diet. When to wean and taper the patient of ketogenic diet therapy. This is after the seizure completely stops. EEG should normalize and remain stable for 2 to 4 years. The patient and the caregiver not willing to continue on the ketogenic diet therapy. Since there's no compliance, we try to counsel them and make them understand the importance of staying on ketogenic diet. But if it still doesn't work, then we gradually wean them off. No adequate seizure control after 3 months on ketogenic diet. So this was a study by Dr. Eric Kosoff and even other doctors and dietitians, of which Dr. Nathan was also a part of it. So this was optimal clinical management of children receiving dietary therapies for epilepsy and updated recommendations of the International Ketogenic Diet Study Group. So they observed that KD should be used for at least a mean of 3 months in order to make a fair assessment for efficacy. If seizures worsen for more than 1 or 2 weeks after starting ketogenic diet, similar to anti-seizure medications, it should be discontinued immediately. In children with more than 50% seizure reduction, the ketogenic diet was often discontinued after approximately 2 years. And children with more than 90% seizure reduction and side effects are low, ketogenic diet can be continued for several years. Shorter durations would be appropriate for patients with infantile spasms and status epilepticus, but longer diet durations would be necessary for GLUT1 and PDHD patients. Prior to ketogenic diet discontinuation in seizure-free children, routine EEG would be valuable to counsel the families regarding the recurrence risk. And if classical KD can be discontinued abruptly in an emergency situation, it can be done preferably in an inpatient setting, but more often it is done gradually over several months, that is 1 to 3 months. How to wean and taper the patient of ketogenic diet. The diet should be discontinued gradually and under continued supervision of the KD team to prevent the rebound seizures. For those who are on KD therapy for fewer than 3 months, the carbohydrate content can be increased gradually by 1 to 5 gram net carbohydrate per week, or by a 0.5 decrease in diet keto ratio per week till the ketosis is lost. For those on long-term therapy, this process should continue over the course of weeks to months. If the seizures or other side effects occur with weaning, the KD should be resumed at the last point where it was effective. Once the ketones is lost and if the seizures remain stable, then the patients are encouraged to continue to adhere to an overall healthy diet, which is low in processed foods, especially in sugars, jaggery, and honey. We recommend them to stay off sugar, jaggery, and honey at least for 1 year post stopping the ketogenic diet. I would recommend you all to check out this paper, this article. This is available on PubMed and gives a lot of valuable information on the follow-up, fine-tuning, and weaning of ketogenic diet therapy. Thank you.
Thank you, Sonal, for the comprehensive, nevertheless nicely delivered talk. We'll move ahead to the third speaker of tonight, Dietitian Ritu Sutkar. She's a registered dietitian with Indian Dietetic Association. She works since 2013 in Dainand Medical College and Hospital in India. And she has an experience over 22 years in clinical nutrition. She undertook special training to design ketogenic diet and treatment for uncontrolled epilepsies and has successfully practicing it on a number of patients. She attends and presented in a number of international symposia pertaining to ketogenic diet and diet in neurological disorder and presented posters in the same throughout the years.
Dr. Samar, if you will give me a few minutes before
Sure, Doctor.
Ritu Sutkar, before her presentation, I'm going to show something which is really interesting. Can high ketosis worsen the seizures? Everyone can see this?
Yes.
Okay, so this is a few of our patients. I actually learned it from one of the mothers, because she said once the ketosis goes a little high, his seizures seem to be becoming worse, and they do seem to become worse. And would you be able to bring down the ketosis and see what happens? Okay, now this is case number 1. So a 7-year-old on a ratio of 3:1. So at that time we were doing only the urine ketone. So I said, no, you better come here. I will check the blood ketone and see what it is. And the blood ketone was high. As you can see, 10 milligram per deciliter, and the seizures were 9 to 10 seizures per minute. After that, I reduced the ratio, the blood ketones dropped, and the seizures stopped immediately. I'm sorry, that 9 to 10 seizures is per month. By mistake, I think that is a typographical error. It was 9 to 10 seizures per month. But the moral is that sometimes if your blood ketone is high, actually the seizures can get worse. The second patient had 10 to 15 seizures per day on a ratio of 2.25, and the blood ketone was just 3 to 3.5, which is not really very high. But in spite of that, the mother said, I think when he was on a lower ratio, he was a little better. So we dropped the ratio and sure enough, the blood ketones fell to 1 to 2. Now that's not very high at all. And the seizures dropped to 1 to 2 per day. So once again showing you it's not just the blood ketone, it's again very individual. Someone may have higher seizures when the blood ketone is really high, like 10 milligram, and it may fall when you bring it in the usual range we say is around maybe 2.5 to 4, and then that works the best. But here, even though it was between 2.5 to 4, it seemed to be that this child did much better on a lower blood ketone. And the last is, he was on a slightly higher ketone, 6 to 7 per day. 6 to 7 was the blood ketone level, and seizures were over 100 per day. And when we dropped the ratio, the blood ketones dropped to what is fair, 3 to 3.7, and the seizures immediately dropped. So this does show that at times you will have to fine-tune depending upon the individual. So time and time again, we really don't know. Does someone respond to a lower ketone level better than a higher ketone level? Does someone need a higher ketone level? It's very, very difficult. So I hope all of you will take this lesson home, that every patient is an individual. You cannot go by what you read, you cannot go by the data, and I will show some other things at the later stage. And I now hand it back to you, and we will be getting Ritu Sudhakar's. So the presentation is coming up. So many things.
Yeah, hi everyone. This is Ritu Sutkar, Chief Dietitian at Baran Medical College Hospital, Ludhiana, and I'll be talking to you about strategies to improve compliance in delivery of ketogenic diet. There's a famous proverb that says that you can lead a horse to water, but you can't make it drink. Yes, so ketogenic diet can really be difficult because you can all guide, but then whether how to improve compliance, you can't really force the patients to go in for that diet. So let's see how we can actually improve compliance so that the horse goes towards the water. So what is compliance or adherence? So adherence is the extent to which a person's behavior it would correspond with recommendations from a healthcare provider. And terms adherence and compliance, they're often used interchangeably in the literature. And trust me, adherence is the single most important modifiable factor that compromises the treatment outcome. There's certain barriers to dietary changes, like it could be decision making, it could be social and cultural factors, it could be patients or individuals' preference and perception, and even cultural, environmental, and financial barriers. So what are the strategies that we can follow to ensure adherence? Education and motivation is the first and the most important strategy that we have to follow. Understanding the rationale for the required dietary change is very necessary condition for a change. So the information that we provide to the patients or the caregivers should be sensitive to the individuals or the group's characteristics, including the attitudes, cultural norms, and literacy skills. Also, the strategies that are aimed at motivating individuals to change their diets, it involves enhancing outcome expectations. So we have to tell the patients that yes, if they kind of make this a particular change to the diet, or if this switch over to a ketogenic diet, the purpose is a better outcome. So that would kind of motivate the patients to go in for a required change. Realistic meal planning is other very important strategy. So the diet plans that we give to the patients, they must be easy to adhere to. They must be culturally and financially viable. They must have some foods, at least some foods that the patient likes. And it must be easy for the individual to cook or procure. It should have cooking tips, recipes, shortcuts, and even preservation tips. So in short, I could say that it should have more of what you can eat rather than what you cannot eat. There is whole lot of availability of new foods in the market, and it's actually flooded with foods which can be used for people with the on ketogenic diet after maybe calculating them into the plan. So these foods can be used to improve participant adherence to dietary protocols and goals, and which require reduced or increased intake of specific nutrients. So the information on these commercially available foods, which are usually ready to eat and easier to procure, it should be provided by the dietitian to the patient. So some examples could be like soy-based foods, keto crackers, chocolates, beverages, flours, etc. And you can see this is a picture of certain foods which are easily available over the net. You can kind of order them online. So similarly, they would, foods available in your area, which the patient can actually easily procure. So list of those foods should be given to the patient, and this goes a long way in ensuring compliance because variety is something that everyone wants. Another important strategy is to have support group interactions. It's been seen that interactions with supportive others can improve adherence to dietary changes. Peers, nutritionists, and family, they can provide emotional support as well as challenge negative expectations regarding the proposed change. I'm sure you all know that Sanjeev Clinic, Dr. Nathan's clinic, it has a WhatsApp group with the dietitian. So a patient's WhatsApp group with the dietitian who checks for the contents and provides her inputs as and when required. In my case, I don't have a support group as such, but yes, I provide 24/7 WhatsApp support to my patients. See, if whenever they get stuck, they know that they can message me on WhatsApp, and I'm quite a pro in checking my WhatsApp messages. So they usually tend to get replies to their issues or messages within 5 to 10 minutes, which they really like. And, I'm quite confident that this has improved the compliance of this diet in my patients and similarly others. So this is something that I don't think I should be even discussing now, because for the past 2 days of the conference, of the workshop, you've been listening to this, that what are the different type of ketogenic diets and how does classic ketogenic diet differ from modified Atkins diet, etc. So talking about who are the people, or who all can affect compliance. Compliance can be affected at the level of the patients, caregivers, as well as dietitians. So patients would have different challenges, like rigidity or lesser variety of diet, the taste and palatability, or inability to include staples. Like in India, we are so much used to eating wheat and rice, and there are staples. Soy is really not a staple. So Indian patients have lot of issues that, like, how can this kind of survive without eating wheat or rice for years? Then there are social issues. There can be difficulty in eating out. And when it comes to caregivers, I think they're the worst hit. You can see, a usual, you can expect a keto mother to look somewhat like this. So I let working in the kitchen. So cumbersome weighing of ingredients, time consuming to prepare special meals, then even cost and affordability is an issue with some caregivers, and lack of enough education and commitment among parents can also lead to poor compliance. And when it comes to professional help like dietitians, not all centers that do provide ketogenic diet prescription have a dedicated keto dietitian. So non-availability of a dedicated keto dietitian or not providing enough support to the patient from the dietitian in terms of variety, the number of recipes, demonstration of recipes, clearing of doubts, etc. So these all are the challenges that lead to poor compliance. So the next big question is that, can we improve compliance? Definitely yes. There's few things that every keto dietitian needs to do to improve compliance. So that is, we have to provide adequate and good variety to the patient in terms of recipes and ingredients, number of meals, so that would really goes a long way in improving compliance. So there should be kind of enough number of recipes for each type of meal, like snacks, beverages, desserts, main meals. Then there should also be provision for tiffin meals, because there could be keto kids going to school. And then, all kids and elders, maybe whosoever are on ketogenic diet, they like to have some special meals for their birthdays. And if they want to eat out, what are the recipes that they can actually eat? So I think use of exchange list helps the patients and the caregivers a lot in developing new recipes on their own, or making small changes in the recipes that given by the dietitian if they do not have all the ingredients at hand. And so flexibility and variety in food selection, it should be greatly encouraged. And we should emphasize simplicity and practicality while designing and while cooking a menu. So we should include foods appropriate for ethnic, cultural, and social background of the patient and family. And we should encourage that the extended family eats together, thus minimizing feeling different from the family and peers. Because most people, even if they're doing well, especially on modified Atkins diet, where you don't have to actually weigh the fat that you're using, patients at times feel that they were having a very good ketosis and suddenly it's gone down. So, and which could have happened due to reduced fat intake in a particular meal. So, instructions like this, which could help use more fat in the same menu, should be given, and it should be told to the patient. Like if they cut and chop small pieces of fish, chicken, or mutton and deep fry before using. Then similarly, when it comes to vegetables, those permitted amount of vegetables can be chopped and then deep fried before using in recipes as such. And patients should be, educated that scrambled form of egg can hold more fat. Then increase, using mayonnaise really helps a lot in improving the fat content of the diet. So if you talk of an Indian recipe, something like dal makhani, wherein you can add any amount of butter, ghee, or mayonnaise to the dal, and it really comes out with a great ketotic effect. So similarly, you could, if for Western recipes and other recipes, we could use mayonnaise in mincemeat and other recipes to increase the fat content without affecting the taste. In fact, rather improving the taste. Then butter toffees can be used for garnishing. And then how to use liberal amount of oil for making gruels, custards, pancakes, etc. Very important thing is, because as we just learned that most often the major challenge that the food givers or the caregivers they face is time. That they feel that cooking special meals every now and then, weighing the ingredients, that it comes to it costs them a lot of time. So it's seen that initial weeks they may cost extra an hour or two of commitment, but with time this comes down to about half an hour, because if the caregiver learns how to weigh things beforehand and how to cook multiple recipes together, we'll be talking about those. So that can be a very big time saver. And those, these tips, it's the dietitian's prerogative to suggest to the caregivers. So preparing and storing meals or parts of the meal in advance can save much time. They can be told how they could chop vegetables and refrigerate in a Ziploc. Cream popsicles, can be used over the whole week, and they can be made once a week, not rather than making one popsicle every single day. Similarly, they could measure a day or two of meals at a time and put in containers and label the ingredients. And, for working mothers, wherein they feel that at times, early morning, it becomes very difficult for them to, give a meal to the child who wants to go to school. So they can pack some cold, ready to eat meals in the fridge, so that in cases of emergency, when they are not available or suppose the mother is traveling, so at least the child himself or herself can, pick a ready meal from the fridge and eat. So more time-saving techniques like, planning a day's menu rather than just cooking. Planning and making choices a day in advance goes a long way. So all, usually mothers, this, this is what we have tried, that, once the child gets up, if it's a small child, mothers say that they keep us busy. So I usually tell them to just get up 10 minutes earlier and weigh all the foods in one go, and in the morning when everyone else is kind of sleeping and there is, peace at home, so they can keep in small tight stackable boxes. So this would save effort and time while cooking and serving. If you have pre-weighed ingredients well labeled, it actually doesn't need much time to cook. Similarly, there's certain foods that can be, cooked multiple servings together. Like, if they were to bake a cake, then weigh and divide the cooked product into a number of servings planned, rather than baking a number of button cakes separately. So, okay, 10 servings of cake, weigh together, bake one cake, and then once the cake is baked, divide it into 10 equal cooked servings and freeze, right? So similarly, bake cookies together rather than one every day. So most recipes that can be refrigerated or used after defrosting, they can be cooked and packed separately at a single go for a multiple use. Like, it could be ice cream, it could be popsicles, as I said, puddings, curries, whatever. So another important challenge is that traveling. So what are the meals on the go that people can have, and how do they carry? So, simple suggestions like cold food is easier to transport than hot food, that they could carry a small cooler with ice packs in which they can carry cooked food, cold food. Soup, if it has to be carried, it could be carried in a thermos. And for a camping kind of a holiday wherein the family expects to stay a few days out of home, they can carry a camping stove, pre-weighed ingredients and supplements along with, so that it would be easy for them to cook then and there. Then also, many times it's easy to get a food microwaved in a restaurant. So if they're planning to go out or eat out, they should make sure that the restaurant has a microwave. They can call and check. And then rather than just, serving the food in the disposable box or something that they're carrying, have the food nicely plated. And that would have a great impact on the child whom the food is served, because he would feel that they're kind of almost eating everything similar to what others are eating. And so it's the key to making the diet portable is reusable storage containers. That is something a keto mom cannot do without. So they should have a number of different sizes, a reusable storage container, which could be labeled, especially while traveling or even otherwise day to day also, it really helps a lot. So eggnog, that is egg mixed with milk, soy milk, or with some cream. It's a traditional replacement meal, and it is designed for an all-purpose substitution in case of travel, sickness, or emergencies. And mothers should know about this, because the quickest possible ketogenic meal that one can make. Then, we do have those keto formulae, ready to drink keto formulae, or in the powdered form, they're available. So while traveling, we should tell the patient's parents that they should carry enough amount of that formula with them, so that if at all, due to any reason, they do not have enough time to cook, or they do not have the provision to cook, right? So at least they can mix that formula in water and just feed the patient. So for birthdays and indulgence, we have to basically, it's all, something that a dietitian would do. You have to give them recipes that, okay, if it's a child's birthday, rather than saying that you're not celebrating it or you're not going for a birthday party, a simple cheesecake with some frozen food topped on it, it makes for best birthday eat outs. Child can be given that when he's going for a friend's birthday party, and he can have his own special birthday cake rather than what everyone else is having. So there's so many other, possible ways that you can make interesting recipes if you can just read them. Salad with feta, olives, and olive oil. Then, You could have sandwich, which is simple chicken, turkey, egg, or paneer. Paneer is the Indian cottage cheese. So they're all, mixed with mayo and rolled in a lettuce. They make for a very good keto meal. And similarly, many other, recipes that can be tried for birthday parties. Creativity is something, that is very, very important. And it's actually a lot of calorie-free ways that can be employed to keep the food lively. Just by using different shapes, using molds or cookie cutters, different colors. You can use natural food colors to change the color of the same recipe. Then small amounts of herbs and spices can be used to change the flavor of a particular food. But yes, we have to be very, because at that they can contain carbohydrates. So just maybe a pinch of herbs and spices can do the wonder. And even, it can, then you actually need not count the carbohydrates. So different flavors can be used. So suppose it's a whipped cream kind of a pudding. So if you use a mango flavor, the same whipped cream can taste like a mango with the chocolate flavor, with the rose flavor. So you can use different extracts like vanilla, rose, whichever you want. And serving in smaller plates, decorated plates, that also helps, makes the food more attractive. Like, cucumbers, if you just take an example, cucumbers could be cut, they could be chopped, they could be diced, cubed. And otherwise, if it's like, you're supposed to give a pizza slice to a child, maybe just a slice of tomato or cucumber topped with beef, chicken, or fish, and then a lot of melted cheese. It would make for a quick and attractive pizza slice. So it's a mother or a caregiver who can make the diet work for the child and for the family. So being creative, careful, and planning in advance, it goes a long way. But yes, there are certain diet tools that, this is from our experience, that there have been families who just, stop going out because their child is on a special diet. So in that case, the child actually requested his parents that he would stick to whatever is being fed to him. He would not ask for any special meals, and he would like to have his keto meals only. But he wanted to go out of the house with the family for an outing or for, a stay out. And similarly, a mother who was like very, that if the child goes to school, he or she may cheat, or he may be tempted by what other students are getting in their tiffin. So she, simply hired a home teacher rather than allowing the child to go to school. So all these things are something which should not be done. It is better to aim for inclusiveness for living as normally as possible, because this diet definitely is restrictive. So we have to, make sure that you feel as normal as ever even while on this diet. So if you see, this is a publication which says that, which actually, if you go through the details, you would actually be able to judge the time that a dietitian spends, a keto dietitian spends with her patients on ketogenic diet. So it's actually the dietitian who can make or break the diet. She spends maximum time with the patient, beginning from initiation till culmination of the diet. She is the one who needs to be in constant contact with the patient. She takes regular follow-ups, phone calls, provides WhatsApp support. Then she is the one who suggests variety ingredients, meal planning, how to read food labels, source of carbohydrates. And I mean, it's actually, only the dietitian who can actually educate, motivate, provide information of foods, brings about behavior change. So everywhere it's the dietitian that has a role to play. So dietitian can actually make a horse drink water. So it's like, it's in your hand, dietitians, that, you provide variety, and through all the determinants that we just discussed, if you're committed enough, you are the one who can actually make the diet work. So, and it's many times seen that lack of compliance could also be attributed to intolerability, and they could be due to certain side effects. And, and it's generally not because of less number, and many times it could be due to restrictiveness, that is reduced variety and hence leading to lesser compliance. So there are very few reports of severe or fatal side effects. So it's very much possible that dietitians and neurologists, they make enough and adequate efforts to increase patient compliance, which could in turn increase the efficacy of the diet therapy. So at the end, I think we'd like to say that a diet plan is just as good as adherence to it is. So adherence is very important. Education is the fulcrum on which behavior modification rests. Let your patients understand the problem and even solutions offered to ensure adherence. Realistic, simple meal modification and simple recommendations, they lead to adherence. And along with that, it's peer and family support. They help adherence and they also help in discovering new strategies to cope with the disease. Big thank you to all of you for the patient hearing.
Thank you, Ritu, for this deliciously delivered talk and the very helpful recommendations. I'm gonna introduce our last speaker for this session, Forum Takkar. She will be talking about Keto Calculator. She is a clinical dietitian and nutritionist with Dr. Nathan. She is managing and conducting online webinars and presenting about ketogenic diet and its type. She has published 2 research articles in 2019 about ketogenic diet in multiple sclerosis and subacute sclerosing panencephalitis. She's associated with Ireland Indian Council to conduct various webinars and demonstration of healthy lifestyle. The mic is yours, Dietitian Forum. You can kick off.
Hello everyone, I am Forum Tucker and I'm joining you all from Dublin, Ireland. And my topic today is to demonstrate how to use Keto Diet Calculator. Keto Diet Calculator was designed in 1995 by Beth Kenya. She is the world-renowned keto dietitian and the software developer David Chase. So if you're using Keto Diet Calculator for the first time, I would recommend you to register to the program, send in your details, and Beth will revert back to you with your login ID and password. Once you receive that, this is the home page. You go to the login ID, enter your login ID and password, and this is how the main page of the Keto Diet program looks like. So there's the option of select client, wherein it takes you to the database and you can select the patient that you want to calculate the recipes, or you have an option of add new client when you're adding a new patient for the first time to the program. Apart from that, so when you add a new client, it takes you to a demographics page. And just for the demonstration purpose, I have added a client here, and this is how the page looks like. So it will ask you for the first name, last name, date of birth, gender, and start diet. Approximately, you need to mention the start diet, and then there will be email ID, medical record number, and if you want to give access to your client to design their meals, this will be the login ID and password that you can give. It will only give them access to plan to their meals, snacks, and they can plan the meal or the menu for the week from the weekly menu planner, but they may not be able to access the entire database of yours. So this is how it looks like. Apart from that, now let's move on to the most important part of diet calculations. This one is the diet calculation for this patient. He is 12 years, 6 months old, and this is the current diet, which is 1500 calories. Ideal body weight was 35, ratio 3:1, and number of meals per day is 4 grams. Now, if you want to change the diet calculation, say for example, if you want to reduce the ratio, what we have to do is change diet calculation. It will prompt you that once you make changes here, the recipes will be changed, the calculation for the recipes will be changed. So you do okay, add desirable weight, which is again, I will add as 35. Calories, same as 1500. And ratio. Ratios, they have an option from 1:1 to 5:1. I will select it as 2.5:1. Number of meals I will keep as 4. Type of diet is oral again. Sorry. And the protein here, if you notice, the protein they have calculated as on the basis of 1 gram per kg ideal body weight. This you can change, which will automatically change the amount of carbs. So fat is calculated, and protein is something that you can change, and it will reflect onto the carbs. Everything here, all these amounts are in grams. So this is the amount of all the macronutrients in grams. Then you save the diet, and this is what it reflects. So these are the changes that you have made. Now, when you go to create or display meals, this is the meal options, and there are a lot of meals that you can create. There are certain standard meals. I will leave this option for you to explore. So there are certain standard meals that are already added in the database along with the recipes, and all you have to do is adjust the amounts of each of the ingredient to meet your goals of ratio and other macronutrients. What I have done is I have done add scratch meal. So in add scratch meal, you'll get a blank page like this, wherein you can add, say for example, fruit milkshake, insert meal, and you will get this as blank, wherein you can go and start adding each ingredient. So for example, fruit A is from our database, and you can add soy milk, and you can add oil, like for example, say olive oil, and then you can adjust the macronutrients accordingly to meet your goal. So for example, if I do this, say 40 grams, I'm getting 4 carbohydrate, fruit being the one carbohydrate source, and I'll keep this to 41 for now. Soy milk, I'll keep it to and you can keep on adjusting this one here, right? So it's 300, and olive and oil, it can go to 31. So this has given me the ratio of 2.54:1. The calories is 379, from the goal being 375 kilocalories. My macronutrients, I can see maybe fat is a little high. Let's fine tune it and see. This looks fine to me. So this is how you plan and you save the recipe. Fruit A, fruit B, as you can, fruit A and soy milk, as you can see, is in blue because the nutritional value of these ingredients are being added by us in the database, and the olive oil here looks black, so it is the nutrition value of olive oil here is from the master database. So I have saved the recipe, but you may not be able to print or email this recipe because you have to select verified by nutritionist and save this recipe. Now it is ready to be emailed or printed. Apart from that, so you see this recipe is verified by nutritionist. These two are not. So similarly, you can adjust this recipe and you can calculate this recipe and send it. So just to fine tune this recipe a little bit, this recipe seems fine to me. So just verify it a little bit. So this looks fine to me with fine tuning of some amount of fat. By increasing 1 gram of fat, you can see the ratio is 2.53 instead of 2.5, which seems fine. And that's how you save the recipe. Now, for example, if you want to change this recipe, use just one group of vegetables. This is if you select and save, this vegetable will get deleted and you will be left with only vegetable B, hen, egg, and olive oil. So the client will only be able to use vegetable B with the grams that you calculate and egg and olive oil. So I will not make these changes for now. You can reset this meal 0 to 0 and recalculate it again. Add new foods if you want to add any of the food component. Now, apart from that, so again, this is verified. Now, I will not go on to calculation, showing you calculations of chicken soup. I will explore other options. There's the option of create display snacks. If you want to add some midnight snack or midday snack for the child, you can do that. Then these options are about the vitamin or medication profile. If you want to add any fluid schedule to the diet, this is a weekly menu planner wherein the caregivers can plan the menu throughout the week from the given recipes. There's FAQ where there are more than 7,000 questions answered by Beth herself. Then there's helpline. If you cannot find your answers in FAQs, you can always connect to Beth and ask your questions regarding the program or ketogenic diet. There's a toolkit, very important. All the PDFs are here, which you can download. There's the option of nutritionist guide that will help you understand how to use this program. There's the table maintenance, wherein this is where food items is where you add the nutritional value of the products that you want to use. So the ones in the black are the master database, and the ones in the blue are the ones that you will add the nutritional value of the products that you will add for your clients. Apart from that, there is the option of organization settings, very important if you want to give access to other dietitians from your team. This is where you will find the this is where you can create the login details for your team members. I would like to say that it's a very easy program and it is very self-explanatory. The toolkit will have all the details of the program, how to use, and will answer most of your queries. So please explore this program, and I'm sure you will enjoy calculating keto recipes using Keto Diet Calculator. And I would like to give again the credit to Beth and David Chase for designing this amazing program, and it is free to use for everyone. So I hope you enjoy this, and please feel free to ask your questions if you have any. And thank you for this opportunity.
Thank you, Forum, for the nice demonstration. Now we will go to the question and answers. I'll start with the dietitian Hira. Are you around?
Yes, I'm around here.
Yeah, there is two questions for you actually. One is from Iran. I'm practicing in Iran on strong sanction. We are not able to afford KetoCal. We do not have any formula to begin with the diet actually. Is there any advice to help me?
Sorry, dietitian, I didn't hear your question properly. Dr. Samar, sorry.
Hi, it's for Dr. Hira, for dietitian Hira actually.
Ji.
Hira.
Yeah.
Hira.
Hira.
Okay. So yes, if you are not available with the KetoCal, you can use any kitchen-based blend rice diet or any formula, any standard formula by adjusting their carbohydrate, fat, and protein. You can use this as well, but keeping in mind the glycemic index of that formula.
Right. The second question is, in my center, one case got seizure-free at 2+. Can you explain the reason for this?
Yeah, Hira, you want me to answer that?
Sorry, I didn't hear you properly. Can you please repeat the question?
So one child got seizure freedom on 2+ ketones. Can you explain the reason?
Yeah. Dr. Janak can answer this.
I
Okay.
can answer
Uh,
also. Dr. Janak, if that's okay. As you said,
Sure.
I think it's related to more the blood ketones, and I think they are measuring the urine ketones. So sometimes we see even with 2+ ketones, you can have seizure control. So it's not necessary to go up to 4+. And Dr. Janak will correct me if I'm wrong.
I think it's the the corollary. All the pediatric neurologists and the doctors here, you find with medication, a patient who may get carbamazepine 100 milligram twice a day and is fully controlled, and another child same weight, same age requires 200 milligram twice a day, and someone else needs 300 milligram twice a day. So basically your the dose and at which you have full control is going to be individual. So the dose at which your blood ketone has effect is going to be individual. And I showed you that even in the blood ketone levels, where we found that a blood ketone of 3 to 3.5, the seizures were there, and once we dropped the ketones down to 1.5, the blood ketone 1 to 1.5, the seizures become much less. So how much of ketones are required to control seizures? That is very individual, and you can have anywhere from 1 to 3, and that is the way you have modified Atkins working, where the blood ketones are not very high. So I don't think you should worry about why did the patient improve. He improved. That's the goal. Whether he improved on a 2+ or he improved on 4+ or he improved on 1+, it doesn't matter. Because any time that the glucose drops, seizures improve. The calorie restriction, seizures can improve. And the blood ketone, seizures can improve. So there are many other factors at work.
Thank you, Dr. Nathan. Now, going to Dietitian Sonal. First question is, what are the spices that help in seizure control?
Offhand, it's very difficult to tell you because there are so many spices which help. Please go online. I'll give you again this website, ketogenicdietindia.org. We have divided them into those which reduce seizures, those which are neuroprotective, those which have sedative value, those which are anti-inflammatory. So you have a whole lot, all these spices have various other effects, and once you go online you'll find everything with the lists over there. The ones that we tell them to definitely use, your haldi or your curcumin, then mustard seeds or rye, your jeera, and these are the main things we ask them to use adequately. And pepper powder, that's another thing which is very useful. And remember that if you are giving curcumin, haldi, in order for it to be absorbed, you need some amount of black pepper or piperine, otherwise it won't get absorbed. So that's another thing you have to keep in mind. So the entire thing is all available online.
Right. Thank you. Second question is, if a child on keto diet is admitted in crisis like accident or acute gastroenteritis, what precautions are to be taken by treating intensivist and dietitian?
I'll just go over that question. It's a very long one.
Right. Okay. Next is to dietitian
No,
Ritu.
just a second. I'm answering you.
Oh,
The child is on ketogenic diet, is admitted in crisis like accident. What are the precautions to be taken by the treating intensivist?
Okay, yeah. So this we have faced at times, that they are admitted for something else. So the first thing is, can the child be fed either through an NG tube or orally? If orally, go on with the same diet. If through an NG tube, change the food to an NG meals. And we use the blenderized meals and the liquid meals very, very simply. We don't go in for anything which is the branded or which is expensive. We just use unsweetened soy milk with any oil. And that's so easy to calculate. The proteins may be low. You may need to add raw egg for the albumin and increase the protein. The main thing to tell the doctors, and this I'm going to emphasize, is do not use your dextrose. Do not think that a low blood sugar of 50 or 60 is dangerous for the patient. Many of your patients in ketosis will have blood glucose levels of 60 and 65. And immediately the intensivist will call, oh, he's in hypoglycemia, push dextrose and you increase the seizures. What they don't understand is that there has been work done in the past. This is quite a few years ago, in fact a few decades ago, when the ketogenic diet was in vogue, that once you're in ketosis and your blood ketone is pretty high, the blood sugar, the brain, and this they did in normals, mind you, they did this experimentation in normals. The brain can withstand blood glucose levels of between 45 and 50 even. It's only when you go below 40 that you can have a problem. So that's number one, dextrose not to be used. The second is, many of the intensivists don't understand that syrups have got sugar, and sugar means your ketosis will drop within a few minutes, maybe half an hour, 1 hour. The third I want to tell you is, most of our patients who have some other intercurrent illness, they get a fever, they get a flu, they get something else, they go to the doctor, and because it's a child, they either give some antibiotic with a syrup, or they give, and if the patient's mother is and caregiver is very wise, she'll say, no, I don't want any syrup. Then they will give a tablet which is DT, dispersible tablet. And dispersible tablets have got sugar. Mouth dissolving tablets have got sugar. And then whenever I speak to this pediatrician, they tell me, oh, but there's so little sugar. Oh, why are you bothered about that? Oh, no, we've seen that. You give dispersible tablets for a day or so, and that ketone is dropped from 4 to 2 or 1 or 0. So you cannot allow any dispersible tablets or MD. I've gone now to the extent of saying, if you have an intercurrent illness, go to your pediatrician. I will speak to him personally on the phone. Even after that, I will check each of your medications. In fact, even after speaking to them, they still will write tablets which are dispersible or mouth dissolving. And I think this is all. No, so someone had asked about your breastfeeding. So Hira, would you like to speak about that?
Currently, we do not have any experience of a child who is on breastfeeding, and we started keto on that patient. So currently, we have no experience of running ketogenic diet under 1 year.
Samar, if you don't mind, I'll speak on that.
Yes, please.
Okay, so we have had fair number of patients who are infants who are breastfeeding also. There are 3 ways of doing it. The first is express the breast milk with a pump, mix it with whatever you want, oil or anything, and then feed. You want the breast milk. I think all of you know why. Because it has very high in MCT. And in fact, the infant brain preferentially uses the ketones which come from the MCT. You don't even have to be very high. It can store that for a long period of time, and a child who is breastfed for 6 to 9 months, in fact, will have ketones available for quite a few months after that. I would like either Shenaz or Anaita to tell me why, because you all are the expert, your pediatricians and neonatologists. Why is it that the breast milk which is fed for only 6 to 9 months, yet that infant brain gets enough ketones for 2 to 3 years? Now all of you know that ketone is excellent for neuronal genesis, because you need new neurons, and very important for synaptogenesis, because that's the time when you're pruning your synapses, and the correct linkage between synapses is very important, and that you get from the MCT. So that is one way of getting the milk. The second way is, if supposing the mother, and we've had one or two mothers who say, look, I can't do this pump thing, it's painful. So what we tell them is, feed the breast milk after you have fed around 75% of what we give you as soy milk with oil. So first give a part of the ketogenic diet, maybe 75%, and the rest you give as breast milk. The third, and we have seen this in some of our patients, the mothers insist, no, my child must get breast milk, even up to the age of 1.5 and 2 years old. We've seen this happening. So we say, okay, you give the feed, and then let the child just suck on the breast, because the child is so used to that he either doesn't go to sleep without that, or he makes a big fuss, and he really wants that. So we do all three of these. So again, individual. You'll have to individualize this. So breastfeeding is not a contraindication to use of the ketogenic diet, and we've had many times have this, and I think all of them have done well. I think Dr. Anaita Hegde is there. Anaita, would you be able to also share some light? I'm sure you must be having experience.
Sorry, I just joined Dr. Nathan. I didn't get the.
Okay. Anaita, it's about the breastfeeding. How will you handle an infant who is being breastfed? And I told them basically 3 ways we do it. One is expressing it through a pump and mixing it with the oil and then feeding. Second is feeding 75% of the ketogenic diet and then giving the breast after that. So that it's not only the breast milk. And the third is for those children who just don't go off the breast. The same thing we do. Give them the feed and then allow them to take the breast.
So basically we do the same. We first do the feed, the ketogenic feed, and then we allow a little breast milk. The aim of the breast milk is to get the nutrients as well as to get the immunity that the mom transfers to the child. I think just the fact that containing the seizures and causing arrest of the circuitry of the brain in the neonatal and the paraneonatal period is enough to sustain and give us a long-term benefit over a period of time. I don't actually know whether it's the ketones or the breast milk itself which gives us the long-term ketone benefit. I think just arresting the seizures at that age gives us the long-term benefit. But we do exactly what you do. Give the feed first and then give a smaller breast milk quotient at the end.
My question to you, Dr. Janak, would be, thank you, Anita. I think that's a very important area where I haven't actually started any child with who's younger than 2. No, sorry, not younger than 2, who's primarily on breast milk. What I can say, I have started a couple of infantile spasms on this, but they were already on the bottle. So, which is the youngest age both of you have seen where were on breast milk and then were given the keto, had to stop the keto?
Dr. Samar, just 1 minute. I think you have two, Shahnaz, I think you have 2 devices on in the room. So one of them is giving an echo. Would you put off one, please?
So honestly, the youngest age that we have tried the ketogenic on a child whose breast milk is a few months of age, maybe 2 to 3 months, with intractable seizures, not responding to everything. We've tried the KD on them. I'll be honest, it's not that easy because the breast milk component has a significant amount of sugar in it, which makes it a little difficult. But we manage the top feed as well as the breast milk simultaneously. I mean, we ratio it, so many feeds top and so many feeds breast, or top followed by a little bit of breast. And we seem to manage quite well with that. But it takes a little tweaking. It takes a little time. But for this, there's no option but the formula, the ready-made formula with breast milk.
Yeah, I would agree with Dr. Anaita. We've done it on many occasions. We haven't had any major problem. The major problem is with the mother, not with the infant. The infant accepts it very easily.
Okay, can we go ahead with the next speaker? Dietitian Ritu, I have two questions, actually three questions for you. First question is, what counseling tips are given when children on keto diet wants to attend birthday parties or other family functions?
Dietitian Ritu has a personal emergency, so she's requested me to answer this. So we have, and this is again on the website, Ketogenic Diet India.org has cakes, it has chocolate recipes, it has cookies, it has different breads, it has pizza, naan, ask for it and it's available on the website. So they can have that. Only thing is, make it such that it looks like the other cake which the other kids who are going to be invited, so he doesn't think that he's getting something separate. In fact, tell him this is a special cake only for the birthday boy, the birthday girl, and you decorate it nicely, put a nice candle and give it to the child. Having said that, there was one child of ours, I remember very well, on his 3rd birthday. He did this and he sent us a video where he's running around with the cake and saying that this is my special birthday cake. No one else will get this. So yes, it can be done, and the same thing happens when they go to school. We give them their own box with their lunch or with their midday snack, whatever, and the only thing is, of course, the teacher should be a little cautious, make sure that the child doesn't go around distributing his box and then taking from others.
Right, thank you. The second question, I actually didn't understand, but let's see. When deep frying, do you use leftover oil that is used in the pan, or you use additional to cover up the oil lost? You are muted.
We use spatula to plate.
So what we do is we request them not to use deep frying. Shallow frying, you get more oil into the food that you're cooking than deep frying. So this is one thing I know. Ritu has put this as deep fried, but she comes from the Punjab, and in the Punjab everything is deep fried. Everything. So shallow frying is better. Shallow frying gets more oil in, and what we do is we take off all the fat from the non-stick. We use non-stick pans with the silicone spatula. The silicone spatulas are very efficient in taking out all of this. And when we feed, I wanted to add this, when we feed the child, now what happens sometimes is that these children will eat the carbohydrate and the protein part first, leave all the oil down and then run away. So mix all your meals. When you're feeding, you have to continuously stir and mix it and make sure that you use that. So it should be stirred and all the oil should be used up. When you put adequate spices in the oil will have a good taste. It won't have a bad taste. So in that way, yes, I mean, I'm sure many of us love spicy food with oily food, and we don't mind the oil because of the spice which is in it. It really cuts the oil taste off. And as they say, spice is the variety of life. You must have spices. I wanted to add something here with Ritu put down, mayonnaise. you have to make homemade mayonnaise. You cannot use the mayonnaise which is commercially available, because they put in that sugar. They put in that chemicals and preservatives. So preservatives, chemicals, and most important, sugar. All mayonnaise which is available outside does that. And you have both non-vegetarian mayonnaise and vegetarian mayonnaise. Again, the website ketogenicdietindia.org has I think the videos also or the links to tell you how to make veg mayonnaise and the non-veg mayonnaise.
Okay, thank you. Question is again to you, doctor. What is the specialty of macadamia nuts?
Okay, macadamia nuts, I eat them at times. It's a natural 4:1. 4 grams of fat to 1 gram of protein plus carbohydrates. You can eat that as a meal. and you'll be on 4:1, but you can't eat much of it. I don't know if any of you have tried it. Try it. You can't eat more than 4 or 5, and then you're feeling pretty full. But it's a natural 4:1.
Right. Okay, thank you. Now the next question is for forum. Can neurologists register for the keto calculator?
It's a free app, so it's a free program. So like I said, the neurologist can send their details on the website, and Beth will respond with the login details, and then the neurologist can give access to other team members and the dietitian. So it's free, and there are no charges for that.
Excellent. So you answered the last question, which is what's
Okay,
the
one
cost?
thing I want to add here about Beth.
Yes.
Beth is a very old personal friend. Any problem, just put my name and say Dr. Nathan has referred us. She'll reply immediately, and she'll allow everything. Put also that I want to use this for my entire team. She'll tell you how to do it for the entire team. So it becomes very easy, and those neurologists, I know some of you don't even have a dietitian with you, so you can use that very easily, and Beth replies within 24 hours.
Excellent. So we come to an end. I would like to thank you again.
Sorry, Samar, can I ask
sure.
one question? The question is whether there is, you know of, because again, the blood ketone sticks are not easy to get, and we run out of it, and it's expensive. And so is there a correlation between doing a blood gas and the urine ketones or the blood ketones? Like, has there any study been done where you can do a pH and sort of say, okay, the pH is this much and the PCO2 is this much, and then, okay, the urine ketones are +4. So after that, we really don't know. But beyond that, is there a correlation that you have ever come across?
Shahnaz, is there a correlation between blood ketone and?
The blood pH. The blood gases.
I don't think there's any work done on that. And I don't have
because we don't get the blood ketone.
Personal knowledge of that. But one thing, a person in physiological ketosis, no, this has been worked on. I'm so sorry. A person in physiological ketosis will not be in acidosis. Acidosis begins after you go above a ketone level of 10 to 12. And because of that, I think, this has been worked on even in normals and in diabetic ketoacidosis and on people on the ketogenic diet. So when you are in physiological ketosis, meaning up to 6, 8 and even 10, you will not be in acidosis.
Okay, thank you.
Okay. I think we came to the end of this session. Thanks again for giving me the opportunity to be part of this great session. The mic is back to you, Dr. Nathan.
Okay, I think it's 1:30. We are a little late. We should have finished lunch by now, but we'll give a half an hour break, because I think after the break, there are very interesting topics Very, very interesting. So have a good lunch, hopefully a keto lunch, and come back. Before you leave, of those who are participants and attendees, please fill in your feedback form of the ILAE. The ILAE wants to know whether you enjoyed this program or not. It depends a lot on you, because funding from the ILAE for future webinars and conferences will depend a lot upon whether we have done our job or not. So please fill in your forms before you leave. It's available to all of you. I think it's known as the polls. If you go to polls down below.
No, not polls. They automatically, when they log in, they have a separate
Okay,
window.
when you log in, there's a separate window which will give you the form. So please fill in the entire form and submit it. At the end, there's a button for submitting. So bye bye for now. We'll meet again at 2 p.m. Indian time.
In all